Hi, I'm Laura Snyder. I'm the educator for 5 West, and this is EKG review session. So we're going to try to cover a good chunk of the information that we do in the EKG classes, which is about 12 hours plus of material, and we're going to try to kind of condense that down into about 1 hour. All right, so let's get started. The way I like to start out thinking about EKGs is actually understanding what's going on in the heart itself. Remember, we have oxygenated blood coming in from the lungs into the left atrium, drops down in the left ventricle, and then out through the aorta. After it makes its way through the circulation, of course, it returns back through the vena cava, drops into the right atrium, into the right ventricle, and then pumps into the lungs. All right, so this is sort of the gross anatomy of the heart here. All right. So then when we look at the electrical conduction system of the heart, the way the beat is generated, we're just looking at the electricity itself. It's going to start up in the SA node. The impulse travels through the atrium, or both atriums here. Comes down here, hits the AV node, runs down through the bundle of His, and then it kind of splits through both ventricles. Okay, and then you can see that electrical activity translated onto paper. So that's basically all an EKG is. It's not necessarily telling you what's happening to the heart, whether it's beating or not, but it's telling you what the electrical activity of the heart is. So the cool thing about the heart is that any area of the heart, any cell of the heart, can both receive an impulse and it can generate its own impulse if it decides that it wants to be the pacemaker of the heart. So each area of the heart has its own kind of preset rate. If you're looking at the SA node, that is usually going to run 60 to 100. If the impulse is being generated from the AV node or down in the bundle here, usually that's running about 40 to 60. And then the ventricles, if they're generating the impulses, they're usually running only at about 20 to 40. So what'll happen is the heart kind of prefers the SA node to be the main pacemaker, and typically in a healthy heart it is. But if the SA node fails for some reason, any other cell in the heart can take over. If the AV node kind of notices there's no impulse coming from up above, maybe it will start generating its own beat. All right, so it's kind of a nice fail-safe. All right, so then looking at vectors, the direction that the impulse is moving kind of will tell you whether or not the P wave is going to be upright or upside down. That kind of goes for all the tracings on the EKG. So as long as your impulse is moving from the SA node down like this, you're going to get an upright P wave. Any impulses that are moving backwards like this, you'll get an inverted P wave. All right, so that's kind of something else to think about and understand when you're looking at EKGs. All right, so when we look at the basic components of the complex, you've got your P wave. This represents atrial depolarization. This little bit right here, where it kind of flattens out before it goes into the QRS, this is a little pause where the impulse is in the AV node. So the AV node's job is to basically hold the impulse for a split second before it moves into the ventricle. And that's important because you don't want the atrium and the ventricle to be contracting at the same time. There needs to be that lub-dub to efficiently move the blood the way it's supposed to be. Okay, so this is kind of that little area in the AV node right here where it's kind of doing nothing, it's just hanging out for a second, and then the impulse shoots through the ventricles, making your QRS. and then the whole thing resets right here. Or I should say, really, this is the ventricular repolarization. The repolarization of the atrium usually happens right in here, and we don't see it because it's hidden in the QRS. So the PR interval, basically that is going to start from the beginning, just from right here to right here, to the beginning of this QRS here. Okay. Again, this is your atrial depolarization, and then that time that it spends in the AV node. The normal that you're going to want to look for is 0.12 to 0.20 seconds. And then we'll talk about how to measure time in a minute here. The QRS complex represents ventricular depolarization. There's usually like two waves. They're kind of combined into one. And that's why you kind of get this down, up, down kind of look most of the time. The normal on this is 0.06 to 0.10 seconds. Then your ST segment starts at the beginning of the QRS complex, it goes till the beginning of the T wave, right here. And it should be at the baseline. So the baseline that we talk about starts right here, and then comes after this T wave. So if you were to draw an imaginary line between these, it's hard to draw here. This should be hitting at the baseline, right? Otherwise, you can have ST elevation, it's up here, or you could have ST depression, just down here, all right? The T wave represents the ventricular repolarization. It's somewhat asymmetrical. You can see it kind of slopes this way and then kind of a fast downstroke. QT interval. You can see it starts at the beginning of the Q right here and ends at the end of the T. The QT interval is going to change. It's the one part of the heart rhythm that will lengthen or shorten depending on the rate of the heart. So once the heart speeds up, the QT will shorten. Once the heart rate slows down, the QT will get longer. So what we tried to figure out is the QTC, or the corrected QT. And basically what that's doing is it kind of feeds all that information into an equation, taking the heart rate into account, and then it kind of gives you a rate that tells you what the QT would be if the heart rate was 60. That way you can kind of compare apples to apples when you're looking at patients' QTs. So once the myocardial cells have depolarized, there's a period where they are refractory or they can't take another depolarization. So during this little phase here, where you're on kind of the back half of the T wave, probably about half the cells are depolarized, and that's important to understand because if there were to be a PVC or something that lands right here on the back half of the T, there's a chance that it could throw the whole heart into torsades or like a polymorphic VTAC. So that's why the QT is important to understand on your patient. QTC should be less than 0.5 seconds as a general rule. You'll see it different ranges sometimes for women versus men, versus depending on what kind of medication they're taking, but as a rule of thumb, 0.5 seconds is what your QTC should be less than. Patients can have lengthened QTs depending on what kind of medications they're getting. A lot of psychiatric meds will prolong QTs. A lot of the different kinds of meds that we give will do this. Electrolyte abnormalities can also lengthen the QT, especially magnesium. So a lot of times magnesium is what we're going to want to give to try to tighten up that QT interval. So then looking at the rhythm strip, there's a couple different ways that we can go about using the rhythm strip. There is, if we're trying to calculate the heart rate, you can do the 6-second method. With that, we're looking at the paper. You can see there are little hash marks here. There's a little one here at 3 seconds, and then at 6 seconds. Usually these little hash marks come every 6 seconds worth of paper. Okay, so if you count all the complexes right here in 6 seconds, multiply by 10, that will give you the heart rate in a minute. The other thing that you can do is the 1500 method. So with that one, you're counting the number of small boxes in between a complex. If you're looking at maybe 2 QRS complexes, you're going to count the small boxes in between and divide 1500 by the number of small boxes, and that will give you a heart rate as well. So if you have kind of an irregular heart rate, usually the 6-second method is going to be better for you. If you have a really fast rhythm and it's regular, the 1500 method works as well. That's just how to count the rate. So when we're looking at strips and we're trying to analyze what the full rhythm is, first thing you're going to want to do is analyze the rhythm. So if we're looking at this strip here, you're first going to say, all right, what's the rhythm? Is it regular or irregular? In this case, it seems to be very regular. We're seeing nice regular beats here. Okay. Second step, you're going to interpret the rate. So if this is a 6-second strip, we'll say there's 1, 2, 3, 4, 5, 6, 7 complexes here, which gives you a rate of 70. All right. Third, you're going to analyze the P waves. First, you're going to say, are there P waves? Is there a P wave for every QRS? Do they all look the same? Do they look normal? In the case of this strip, they do. You have a P wave consistently before the QRS. They all look the same. They all look pretty normal. All right. Then you're going to look at the PR intervals. Remember, that's measuring from about here over to here. Is the measurement normal? And this looks like, let's see, if we were measuring, say we'll measure this one, that looks like it fell pretty close to the dark line here. We're going to say that's the start of the P wave. This is the start of the QRS. So that's right around, I don't know, maybe 0.16, 0.20. So I would say that that measurement is normal and that PR interval is the same with every complex. Fifth, you are going to evaluate the QRS complex. Is there a QRS for every P wave? Does it look normal? Are all the complexes the same? They are. What's the measurement? I would say looking at this, it's probably around like maybe 2 small boxes, which gives you 0.08, so that's normal. So that looks good. Then you're going to evaluate the T waves. Do they all look the same? Do they look pretty normal? Is there one for every complex? Yes. So your T waves here look good. QT interval, of course, we're not going to get a QTC with this. We don't have our calculators. I don't know the formula off the top of my head. But another rule of thumb when you're trying to do a kind of a glance overview of the QTC, look at the distance between 2 complexes here, between 2 QRSs, and then go about halfway down. Now if you're T wave is on the left side over here, which it is. You should be in pretty good shape. If your T wave is starting to land after the halfway point over here, that would be a prolonged QT, right? Then you're going to look at basically anything extra. Do you see anything else? Are there any extra beats here? Do you see any PVCs? Does the ST segment look elevated or depressed? Do you see anything else going on with this? And with this particular strip, I don't. And then you're just going to kind of evaluate what's the significance of the strip that I just looked at. In this case, it's sinus rhythm. It looks pretty good. It's not VTAC, all right? So it kind of depends on what you decide the strip is, and then you go from there, decide what you want to do to help the patient. All right, so now we are going to get into some of the rhythms. So we're going to start with sinus rhythms. Sinus rhythms are all originating in the SA node. That's the primary pacemaker of the heart. That's where we expect to see all the impulses generated in a healthy person. All the P waves should be upright. They should all look the same, and all of your PR intervals should be the same as well. So first one here, normal sinus rhythm. You see you've got P waves, your measurement's good, everything looks normal there. You've got your QRS, that looks normal. This is pretty much your classic normal sinus rhythm, all right? The rate for normal sinus rhythm is going to be 60 to 100. All right, next up, sinus Brady. It's sinus rhythm, but it is slower than 60. All right, you still have P waves, one for every QRS. You got your T wave, but then you've just got kind of a nice pause there before the next one. All right, but otherwise everything looks normal. Its rate keeps on track like it's supposed to. Next up, sinus tach. So now we've got sinus rhythm. This is faster than 100. So we've got 100 to 150. Generally, it kind of caps out at 150 because the SA node can really only fire so fast. Kind of rule of thumb on that is that sinus tach would not be faster than 150 or so. All right, then we have sinus arrhythmia. So this is slightly irregular. You can see it's kind of staying on beat here, and then this one kind of slows down, and this one kind of slows down, and then it speeds back up. But your PR intervals are all the same, no matter what. Your P waves still look the same, and it'll kind of continue to follow this pattern. If we were able to see the rest of the strip off here, you would see it slow down again and speed back up. We usually see this with patients maybe with COPD or respiratory problems. It's normal in children, actually, but it's associated with the breathing patterns. Okay. All right, then we get into sinus blocks, pauses, and sinus arrest. All right, so first up, a block. That is a complete block or failure of the sinus node to either capture or depolarize the atrium. The block can last 1, 2, or more cycles, but this pause is an exact multiple of the PR interval. So if we're looking at where the P wave is landing here and here, we expect it to land right here. And if it were to keep on pace, the next one would land here, which it does, and here. So there's basically just a completely missing complex, all right? It's a multiple of the P to P interval, right? Next then we have a pause. This one, the SA node didn't fire on beat like it was supposed to. It kind of waited, had a little hiccup for a while, and then it fired again. So this one doesn't really have this kind of pattern that a block does, but it just kind of slowed down for a minute and then remembered it was supposed to be doing something and fired again. Sinus arrest is longer than a sinus pause, and it's also not a multiple. So they consider that a very long delay of the sinus node to go off again. There's no real clear cutoff between a sinus pause and a sinus arrest. What we tell people is that if this pause lasts longer than 3 P-to-P intervals, it would be considered a sinus arrest. And if you call the doctor and you say, oh, the patient had a 3-second pause or a 3-second arrest, they're not going to give you a hard time about that. It essentially is going to mean the same thing. All right. Now on to atrial rhythms. Here the impulse is going to start in the atria, but it's not always in the SA node. All right. So remember, this is going to be somewhere up in the top half of the heart, but it might not be that one sinus node. So first we have the ectopic atrial rhythm. So when we talk about ectopic, one of the first things that we think about is ectopic pregnancy, I think. And really what that means is that there's something where it shouldn't be. So basically here, a different cell in the atrium is taking over to become the new pacemaker of the heart. Maybe the SA node didn't fire for some reason. Maybe there's just an overambitious atrial cell that decides that it wants to be in charge. But some other cell other than the sinus node or SA node is trying to act as the pacemaker. So the way we can tell this is that you might see, like in this case, you've got an inverted P wave. You know that this can't be sinus because the P wave is inverted. All right. This one down here, at first glance, you might say, well, that's probably a sinus rhythm. And I guess the point of this is to show that it might look like a normal P wave, but if you were to compare this to a patient's earlier EKG strip, you might notice the change, that this P wave looks completely different than how it used to look. But if you didn't have any other information, you may certainly call that a sinus rhythm, so that could be hard to catch. The rate for an ectopic atrial rhythm is considered less than 100. Okay, so the reason here why these are upside down is because there may be a cell somewhere below the SA node that is trying to act like the pacemaker, and when that impulse is traveling backwards, that's causing it, it's moving in the wrong direction, so that's causing that to look inverted. Okay. So different cell other than the sinus node, but it is still up in the atrium somewhere, functioning as the pacemaker, and these are less than 100 for the ectopic. All right. The premature atrial contraction. So here we have an impulse that comes from another cell in the atrium other than the SA node, but it comes early. We know that it's an atrial cell because we do have a P wave, whether it's upright or not, depends on what cell it is. But this complex right here came earlier than we expected. And so did this one over here. And you can see the P waves comparatively look a little bit different from each other. All right. Then we have supraventricular tachycardia, or SVT. So this is from an atrial cell other than the SA node. Remember, we talked about how the SA node will tend to cap off at about 150 at its top, maybe like 160 or so. But SVT you can see up in the 180s, 200 or more, because the other atrial cells may be able to fire faster than the SA node. So it's rapidly firing here. And because these are so close together, you've kind of got P waves and T waves, everything kind of blurring together in the middle. You can't really tell if that is, if that's an atrial tachycardia or if it's a flutter. because you can't really see enough of the complex to decipher. Everything's kind of getting smashed together. And the EKG is looking at everything that's going on electrically at the same time. And it's kind of trying to make one picture out of it. So you're not going to be able to necessarily break apart different parts of the complex with the EKG. You have to look for things that are buried inside it. All right, then we've got the wandering atrial pacemaker, or the WAP. So this one is irregularly irregular, and the rate is less than 100. With this rhythm, you have at least 3 different pacemakers of the heart, or 3 different cells trying to act like the pacemaker. This shows you a little picture. It's 1, 2, 3. You can see they all kind of form their own morphologies, depending on which cell is firing. And because of that, it's going to take different amounts of time to reach the AV node. They're all different distances apart, so you're going to have different PR intervals for all of them. All right. This picture down here kind of shows you maybe pacemaker 1 is firing at this rate, maybe pacemaker 2 is firing a little bit faster at this rate, pacemaker 3 is doing its thing down here a little bit slower, and then maybe the heart rate, or the rest of the heart is only picking up different ones on different speeds. So they all kind of smush together and you get this kind of a complex down here. Then next up, you've got the multifocal atrial tachycardia, or MAT. That is basically the WAP, only it is faster. All right, so this is a WAP that's greater than 100. Again, you have at least 3 different pacemakers competing. You have different P wave morphologies. You can usually pick out at least 3 different ones, and different PR intervals. Like if you look at this complex right here, you can see your P waves upright, but you have kind of a long PR interval. This next one, the P wave is inverted, and it's kind of a shorter PR interval. This third one, you've got kind of a peaked up and down P wave, and then you'll see that kind of repeat. And a lot of times, because the multifocal atrial tach is moving faster, you'll get a lot of blended parts of the rhythm here, like this. You can see the P wave is morphing into the T wave here. So a lot of it can be really hard to make out. All right, also up in the atrium, you've got AFib. So this one is irregularly irregular, and you can't pick out any P waves. In fact, they're not called P waves, they're called F waves, or fibrillation waves. Basically with this, as you can see up in this picture here, you've got random cells firing all over the place in the atrium, which is kind of causing the atrium to just quiver. You never get that strong forceful contraction like you should have with the heart. So it kind of decreases cardiac output a little bit. And then the other problem with AFib, this is a different cross-section of the heart, but we all have kind of left over from the developmental stage of embryos. We have this left atrial appendage over here. It's sort of like this little out pocket in the left atrium. And what will happen is the blood kind of sits down here. It hangs out in this left atrial appendage. And because the atrium just quivers all the time, you never get that forceful contraction that's pushing all the blood down into the ventricles. The blood will kind of run into the ventricles, but it doesn't get that forceful push. So the blood will end up hanging out here for quite some time, and eventually what will happen is a clot forms, and the clot might quiver its way and drop down into the left ventricle, and then it gets ejected up into the brain, causing a stroke or, you know, some other problem. So this is why we need to put our AFib patients on blood thinners. The other thing that they can do is they can actually close off this left atrial appendage, and that's actually what that Watchman device does. Kind of closes that off so you can't get the blood clotting in here. So your strip is going to be irregular like this. You can see your QRSs are kind of coming all at different times, and there's no definitive P wave. It's all just kind of a quivery mess. All right, then a flutter. Again, F waves, not P waves. A lot of times a flutter is regular, but it can be irregular at times. It's got kind of a sawtoothed appearance. You can see this up and down. So what happens with a flutter is there's kind of an extra track that picks up here in the right atrium, where, you know, it should be starting in the SA node, but instead of spreading like it's supposed to, it kind of hops on this little freeway and it just spins around in circles, which is what's causing this up and down, up and down, up and down sawtooth kind of look. Eventually, as it's flying by the AV node, maybe every third, every fourth time that it swings by there, the AV node will go ahead and grab the signal and send it down to the ventricles. So in this case, the AV node is actually acting somewhat protectively. It's trying to keep all of these impulses from flying down into the ventricles. Okay, and that's why you can get different conduction rates here. All right, we're going to move into junctional rhythms. Okay, with junctional rhythms, your impulse is starting at the AV node or the junctional tissue, the bundle of His, somewhere there in the middle of the heart. So with junctional rhythms, your P waves are going to either be absent because they're buried, or they can be inverted, or they can actually land after the QRS in some cases. So you can have an inverted P wave, again, because the signal is traveling backwards. The difference between this and an ectopic atrial beat is that your PR interval is going to be much shorter. It's shorter because the impulse started in the bundle. It doesn't have as far to travel before it starts shooting down the ventricles. So you're going to have a very short PR interval here. In the second example here, your P wave's completely absent, and that's because the atrial depolarization is actually happening at the same time as the ventricle, and it kind of gets lost in the QRS, so we can't see it. This last example, you can actually see the P wave is landing after the QRS. So this is going to be your P wave, believe it or not, after the QRS. And that's happening because the ventricles are actually able to finish depolarizing before the atria. So because your impulses are generated here in the middle of the heart, it has an intrinsic rate that's a little bit different than the atria, and that's going to run a little bit slower. That's running at about 40 to 60 naturally. You might get rhythms that are originating in the junction because maybe the SA node has completely failed, so the junction is kind of picking up the slack, or maybe for some reason the junction is kind of irritated, overexcited, so it decides that it wants to be the pacemaker for a while. All right, so we know what junctional is. That one's running at 40 to 60. If you see a junctional rhythm that is running 60 to 80, that is accelerated junctional. And then you can have junctional tachycardia, which is a rate 100 to 130. So these are all junctional rhythms. They're just at different speeds. That's the only difference between them. Right, then you can have a PJC, or a premature junctional contraction, sort of like the PAC, only this is one single junctional complex. It's coming from junctional tissue, and it's showing you here this This one is your PJC. You can see there's no P wave here. It's just firing early, but no P wave. So that's what would clue you off that it's originating from the junction. All right, then we're moving into ventricular rhythms. So here, nothing worked up in the atrium, nothing happened in the junction, so now the ventricle is going to pick up, and the ventricle wants to try to take over to be the pacemaker. But this is pretty much your last backup. After the ventricle, you don't have anything left. These are really your last resort of the heart here to be the pacemaker. So the impulse is starting below the AV node somewhere, down at the ventricles. You're going to have no P waves and a really wide, bizarre QRS. So first up we have idioventricular. The rate, remember the intrinsic rate for the ventricles is more in the 20 to 40 range, so even slower than the AV node. So here you've got your rate of about 20 to 40. You can see we've got this wide, bizarre QRS. Because this is the last pacemaker of the heart, you really need to fix this pretty quick. Maybe the patient needs a pacemaker, maybe they're on some sort of medication that has done this and needs to be reversed, but you know, you can't really sustain with an idioventricular rhythm running at about 20 for very long. All right, then if you see this idioventricular running a little bit faster in the 40 to 100 range, we would just call that an accelerated idioventricular. So again, no P waves, but we know it's not originating in the junction because we have this kind of wide, bizarre QRS. So that's what sets that one apart. All right, so then we can have PVCs. Just like we talked about PACs and PJCs, this is a premature ventricular contraction. This is an early impulse that comes but originates in the ventricle. So of course you can set that one apart because it's got the wide and bizarre appearance like would come from the ventricle. Whenever you're talking about either PACs, PJCs, PVCs, you always want to name the underlying rhythm as well. So, you know, you could say sinus rhythm with occasional PACs or sinus tach with frequent PVCs. This is just sort of like a little add-on thing that you can see, but it's not the main rhythm. All right, so if you have two PVCs in a row, you would call that a couplet. When you see every other complex is a PVC, that would be called bigeminy, and every third complex is trigeminy. But we see these frequently. All right, getting into everybody's favorite now, heart blocks. So with heart blocks, the problem with heart blocks is a problem in the AV node. So it's either slowing down or stopping communication altogether between the atria and the ventricles. All right. So when we start off with blocks, we're going to talk first about the first degree AV block. So remember, a normal PR interval is 12 to 20 or 0.12 to 0.20 seconds. So here your PR interval is going to be greater than 0.20 seconds. All right, so if we're looking at this complex here, I would say, I don't know, your PR interval is probably, let's see, if you're measuring from, say, like here to here, I don't know, you're probably around like 0.28 or so, which is more than 0.20. Everything else here looks normal though. All right, the QRS is still the same because everything moving through the ventricle is still correct. Everything else is working fine. It's just there is a long slowdown here. Because remember, this is the little point where it's traveling through the AV node. All right. So that's your first degree. All right, it's just a slowing as it's traveling from the atria to the ventricles. All right, next up, you've got your second degree AV block, type 1. Type 1 is the Wenckebach. So this is the longer drop, or longer drop. But with this one, the PR intervals get progressively longer until it drops a QRS altogether. All right, so you can see we've got, here's a P wave right here. Here, let me pick something a little lighter. This is a PR right here. This one here gets a little bit longer. And then this one is missing a QRS altogether. So then you've got short, a little bit longer, and then this one is missing. Okay. So the conduction is slowing in that AV node until it eventually just will drop the QRS and it won't pass into the ventricles at all for that beat. Okay. All right, so then we have the second degree AV block type 2. Here you can see all the PR intervals are staying the same. You don't have that progressive lengthening like you do with the type 1 or the Wenckebach. But what'll happen is you're just randomly dropping QRSs altogether. Here's a P wave, and there's no QRS after it. You're missing one here, you're missing one here. So something's getting stuck or hung up there in the AV node. It's not letting the rest of the signal pass through. This one's a little bit more serious than type 1 because you can't have the signal just randomly getting stuck and not transmitting through at all. You can eventually go into a full third degree heart block. We'll talk about it in a minute. All right, so that's your type 2. All right, no lengthening, everything else stays the same, but you're just randomly dropping QRSs. Okay. So this one is called second degree AV block 2-to-1 or an untypable. With this one, every other QRS is dropped. So because every other one is dropped, we can't really, we don't have enough information to say whether or not you're having progressive lengthening and then dropping, or if it's just randomly dropping, like the type 2. So when you see this 2-to-1 conduction, you know that that's the second degree 2-to-1 or untypable. So when you're looking at this at first glance, you might think that it is sinus Brady, but you do have extra P waves here. You've got a P wave here, here, and here, here. Sometimes this gets confused with a third degree, but one of the ways that we're going to talk about third degree next, but one of the ways that you can tell right off that this is not a third degree is that you have a nice tight QRS that looks normal. And then it's really still on beat. You still have the P and then the QRS everywhere except right here and here. All right, I hope that makes sense in a second. All right, so then we've got the third degree AV block. So here the AV node or the junction, there's something completely wrong in there, and it's not transmitting the signal anymore at all between the atria and the ventricles. So the atria is just working away like it usually does. It has no idea that nothing's happening down below, but it's still generating its impulses. Then the ventricle says, I don't know what's going on upstairs, but I'm not getting any impulse, so I guess I'll just start firing my own. So they're both working completely independently of each other. If you were to break this rhythm up and pull the ventricular beats away from the atrial, this would look sort of like an idioventricular rhythm if you didn't have all these little P waves in here. But basically, so each half of the heart is working completely independently of the other. All right, so you can see your QRSs are right here, 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 here. The P waves get a little bit tougher to pick out. You're going to see a lot of buried and fused complexes in here. But once you start measuring them out, you can see you've got a P wave here, we've got a P wave here. And then let's see, I'm gonna say this one's a P wave. Your next one should land right about here. So I think this right here is actually your P wave. Right. Here, here, here. So you can see they're keeping on rhythm with themselves, but not each other. All right, they're both just kind of doing their own thing. All right, so that is your 3rd degree AV block. So instead of slowed communication between the atria and the ventricle, there's absolutely no communication at all. 3rd degree AV block is an emergency. These people are going to need a pacemaker because the 2 halves of the heart can't go on like this, not functioning along with each other. All right, then you can have bundle branch blocks. This is pretty common in patients, especially people with cardiomyopathy, heart failure, you know, different kinds of problems like that. Basically, this is just a slowed conduction through one or both ventricles. It also will accompany other rhythms, so sort of like a PVC, you would say sinus rhythm with a bundle branch block, or AFib with a bundle branch block. But the problem here is that your QRS is either greater than or equal to 0.12 seconds, because remember your normal QRS is 0.06 to 0.10. So if you see one at 0.12, that's considered a bundle branch block. Depending on the morphology, you can pick out, and this is sometimes hard to do, but you can pick out whether it's a right bundle branch or a left bundle branch block. Usually it's one or the other. It's possible that it's both, but once you get a bundle branch block in both, what I was reading is the next thing that's going to end up happening is you're going to possibly go into like a 3rd degree sort of situation. All right. So this down here kind of shows you the difference in morphology between a right bundle. It tells you if you looked in V1, it might look like that. If you looked in V6, it might look like that. And then your left bundle will kind of look like this. I just grabbed this 12 lead here so you can kind of see how many different morphologies you can have when you're looking at the bundle branch block. You can have a QRS that looks like that. Oops. It's really hard to draw on this. You can have one like this. You can have this kind of wide, crazy, bizarre looking one. It really just depends on what lead you're looking at, what your QRS looks like. Okay. All right, now we're gonna take a quick look at paced rhythms and problems with pacer. So once patients get a pacemaker, when we look at it on a rhythm strip, you're gonna see what we call pacer spikes. You can see these little spikes. Sometimes they're on top of the complex, sometimes they're below. Doesn't really matter for interpretation. When you see a straight up and down line like this, more than likely it's a pacer spike. All right. So you can have apaced. Here we're pacing the atrium. You're going to see the pacer spike right before the P wave. All right. Then you can have V-paced, where you have the spike hitting right before the QRS. And then usually your QRS after ventricular pace is kind of that wide and bizarre look like this. Or you can have a patient with AV pace. So both the atrium and the ventricle is being paced by the pacemaker. You'll see 2 spikes. One comes before the P wave, one comes before the QRS. Pacemakers can be either 100% for a patient, or it can be like a pace on demand, and then it'll kick in only when the patient needs it. All right, so then we've got our pacer problems. A lot of times it's hard for people, they get these mixed up a lot. But first one we look at is fail to pace. All right, for some reason, pacemaker did not fire. You can see we've got little tiny pacer spikes here, 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 and then we've got nothing. And the heart didn't do anything either. So maybe this patient is 100% paced, and the pacemaker just didn't go off. I don't know, maybe the battery's dead, maybe something's wrong with it. Pacemaker did not fire. All right, so that's your fail to pace. Then you've got fail to capture. Basically with this one, the heart is not responding. The pacemaker is working, but the heart is not doing anything with the paced rhythm at all. So you've got your pacer spikes here, here, but there is no rhythm after it. So maybe with this, you might consider something like a lead, a pacemaker lead got pulled out. So the pacemaker is still working, but the heart is not capturing that paced signal at all. And then finally, you've got fail to sense. So part of the pacemaker's job, besides actually generating the impulse, is it actually needs to look at the heart and monitor what the heart is naturally doing on its own. Okay, so people that aren't 100% paced, they may still have some underlying rhythm on their own. The pacemaker needs to watch that so it's able to fire at the correct times. Because again, you don't want it to throw a pacer spike right on a T wave and then throw the patient into VTAC. Okay, so here you can see there is a pacer spike right here. It looks like it's in the middle of a QRS. Here's another pacer spike over here. It's like on top of a T wave. Not really sure what's happening here. Pacemaker's just going kind of berserk. So fail to sense, pacemaker is not sensing what the heart is doing. Okay. All right, then we're going to get into our lethal arrhythmias. These you have to know. You just have to know them. All right. If you know nothing else, please know these. So first up, we have VTAC. Patient might have a pulse. They might not. You want to assess them, see how they're doing. All right. I mean, more than likely you're leaning toward not having a pulse here. This is a shockable rhythm. It can be monomorphic, which is like one form, or polymorphic. Polymorphic is also called torsades de pointe. That's the twisting sort of pattern that you see here. All right. Monomorphic, polymorphic, both are shockable. Both you can give meds. You might need to give CPR. Okay. But either one is VTAC. You're going to treat it basically the same. All right, VFib. No pulse with VFib. All right, you just won't have a pulse. Remember AFib, the atrium is kind of quivering, not really contracting. It's the same thing with VFib, only it's the ventricle quivering. All right, and that's why you get this kind of chaotic, bizarre looking appearance here. Sometimes it's kind of coarse like this, sometimes it's a little bit more fine, but in any case, it's a chaotic rhythm. There's no pulse, and it is shockable. All right, then we have agonal. It's not really a rhythm in itself, but when you look at a rhythm like this, it looks like maybe you're throwing a ventricular beat, every 4 or 5 seconds. This is probably PEA. If you were to see a patient like this is probably not generating a pulse. You can give the patient CPR and meds, but basically when you see a rhythm like this, the heart is dying, and once this stops, it's going to be asystole. All right, and then we do have asystole. All right, there's absolutely no pulse. There's absolutely no electrical activity. The heart is doing nothing at all. You can do CPR and meds on a patient like this, but you can't shock asystole. I mean, you can, but it's not going to do anything because there's no electrical activity happening at all. You see there's like a little bit of baseline up and down like that. Don't be confused that that's VFib, but asystole is not just a perfect flat straight line. It does kind of have just a little bit of waver to it like that. Okay. So tips for tele. if you have a patient that has a rhythm change, print a strip so you can show the doc later. Sometimes it's hard to go back into the monitors, especially if patients move to a new room, something like that. It's hard to get strips from any changes. You should be monitoring your patient's rhythms at the beginning and throughout your shift. You know, even if you're just walking by the monitor and glancing at it, make sure that the rhythm's still the same. The tele room is not able to catch everything. It's kind of your responsibility to keep an eye on your patient's rhythms. You have the luxury of looking at it in the rooms. You know, when you're in there doing your assessment at noon, just glance at the monitor. What's it looking like? You should sit down and interpret your strips at least once per shift. So what that means is you're looking at the strip. You can write on it what the PR interval is, what the QRS is, what the QT is, and then your interpretation. You punch some holes in it, file it in their chart, and then you can also chart that in Epic. There's a spot underneath the cardiac section for that. And you can kind of compare to what the tele room is charting as well and see if you're on track or if they're charting something way different than you. So if you're running into problems, try collaborating with your team. Show it to the doctors that are around. There's always cardiologists rounding. Show it to your fellow nurses, you know, kind of make a game out of it, see who can get the best at doing this, you know. But kind of collaborate, put your heads together, see what you can figure out as far as interpreting your strips. And then you just have to keep up your practice. It really doesn't take that long to run through your strips once you get pretty familiar with it. Not a big deal. And the more you practice, the easier it is. And then you'll get to where you can just glance at the monitor and you've got a pretty good idea of what the rhythm is. All right, so it's just safest for our patients and it is best practice. So if you guys have any questions or anything, be sure to reach out and I'll see what I can do to help you. All right, thanks.